get started. Welcome to another HuMEL webinar. Today's focus is Data Quality Assessments, or DQAs. My name is Allison Simmerly, and I'm a meal advisor at Catholic Relief Services HQ. I'm also a co-chair of the HuMEL peer network, and today I'm joined by Matheson Sharp, who's providing some production support from Save the Children. Before we get started, I'll just cover a few housekeeping rules. If bandwidth allows, please turn your video on when speaking so we can get a better sense of the community members joining us today. Please also remember to mute your microphone when you aren't speaking to cut down on background noise during presentations or Q&A. And we'd really like to hear from you today, so please do feel free to include questions, comments, feedback in the chat throughout the session, and then use the hand raise function to ask questions in our dedicated Q&A periods. Just so you are aware, the session will be recorded today and uploaded to the HuMEL site. All right, before diving into the agenda for today, I did want to briefly preview our next webinar, which will take place in early September and will feature a panel discussion on outcome measurement in humanitarian settings. In that session, we'll explore some tough questions focused on whether or not implementers feel that projects are really achieving intended outcomes for participants. If you feel like you know someone who would be a great fit for this conversation, or you yourself would be interested in serving as a panelist in this session, please share a contact name and email in the Google form that will be linked in the chat shortly. And if you don't have any contacts, but you have a great discussion question for us to explore during the session, those can be shared in that form as well. We're also always eager to receive feedback and ideas for HuMEL via our new Gmail account, humelmanagement@gmail.com, which I'll also put in the chat. All right, so today we'll be hearing from 3 speakers on 2 topics. The first is developments in routine DQAs at International Medical Corps and DQAs for feedback, complaints, and response mechanisms, or FCRM, in Moldova. Each topic will have roughly 20 minutes of presentation, followed by 10 minutes of Q&A. And our first speaker is Jennifer Majer, a senior advisor for meal and research at International Medical Corps. And Jennifer is joined by her colleague and meal officer, Omar Makki, from IMC's Lebanon country office. Jennifer will be presenting IMC's new routine DQA guidelines and toolkit, and Omar will share learnings from recent DQAs conducted in Lebanon. Jennifer, over to you.
Great. Thank you, Allison. Hi, everyone. Very pleased to be with you here today to share a little bit of International Medical Corps' recent work on data quality assessments. So today I'll be talking about the Routine Data Quality Assessment, or RDQA, guide and tool that IMC has recently developed. This is part of our efforts to really try to strengthen our systems for data quality assurance at more of an organizational level. Then I'll be turning it over to my colleague Omar to share his experiences conducting DQAs, specifically at healthcare facilities that IMC supports in Lebanon. Next slide. So starting with the guide, this was really designed to be something of an instruction manual for our staff in country offices who are either leading or participating in a data quality assessment. So it covers key concepts in data quality, including data quality criteria, common problems with data quality, different types and levels of data that are assessed, as well as ethical considerations to keep in mind when conducting DQAs. And it also, most importantly, provides a step-by-step guide for planning and conducting DQA, as well as a tool with scoring criteria. Next slide. So before I share more about the guide and the tool, I wanted to speak a little bit about how it was developed. We finished the guide only very recently in May 2023. And it took about 2 years from the time it was first conceived of until it was finalized and rolled out. IMC's M&E department in the HQ mostly led the development of the tool, but we had some valuable inputs from advisors in our technical unit, specifically related to sector-specific data and considerations for handling that. One of the reasons that it took quite a long time to develop this guide is that there are many complexities around what we refer to as level 1 data. So this is data that consists of individual beneficiary records or records of activities that are conducted at the field level. So we needed to develop practical guidance on how to safely and ethically incorporate level 1 data into the DQA process, where our M&E teams would work very closely with their technical counterparts in country. The guide and tool were finalized, as I said, in just this past May, and we launched the rollout through 2 orientation webinars in June and July. And during these orientation sessions, we asked 2 of our country teams to join and share their experiences and answer questions from other colleagues about how they conducted DQAs and the challenges and best practices that they would recommend. And Omar from IMC Lebanon was actually one of those presenters, which is why I thought it would be very nice for him to join today and share it with the broader global M&E community. Next slide. So we developed the DQA guide and tool using these criteria as a framework: validity, reliability, completeness, timeliness, precision, integrity, and confidentiality. You've probably come across these criteria many times in the past. The reason we use these is that they are very globally applied criteria for assessing data quality across different sectors and fields of work, including in humanitarian programs. So we structured our DQA tool around these criteria and developed specific questions to assess quality against these criteria. Next slide. So the instructions in the guide were also developed based on a data flow that is pretty common for IMC's programs. We often provide services such as health, nutrition, or mental health services from fixed delivery points, such as health facilities. So you can see in this diagram at level 1, patients' individual case files or information from registers is summarized and aggregated at each geographic location, such as a field site, that brings us across the diagram going to the right to level 2 data. And in this diagram, location A and location B would have the aggregated data. Then this information is often further aggregated to a consolidated tracker, such as if we're talking about health data, it could be a country-level database of health consultations. And then this country-level data can be further filtered and subset to enable project-level reporting. So a subset of the data from the country tracker would be entered into the indicator tracking tools. Next slide. So it was important in developing the guide that we made a clear distinction between the different levels of data and how that impacts roles and responsibilities for conducting the DQA. I've referenced quite a bit the level 1 data already. So that's individual level data of patients, clients, or other beneficiaries. So for this data, a quality assessment means looking at issues such as whether case files are complete, whether measurements are recorded correctly. It often includes quite sensitive and protected information. If you could just click one more. such as what we see classified as personal data under the EU's General Data Protection Regulations, the GDPR. So that's things like health data linked to names or phone numbers or other identifiers. Level 2 data, on the other hand, is the aggregated information from level 1 data. So it's a summary of maybe the number of consultations provided. And for level 2 data, our focus is on having M&E teams review the numbers that are reported for consistency across different reports and across the different levels of aggregation and reporting. So reviews of level 2 data can normally be led by M&E staff. However, for level 1 data, we make clear that only authorized staff, and that's normally technical and or clinical staff rather than M&E staff, can review the level 1 data and files where those identifiers are elaborated. So it's important, and we make clear in our guide that technical and M&E staff need to coordinate closely in order to reconcile numbers that are reported to level 2 databases based on level 1 data. Next slide. So in the remaining slides, I'm just going to summarize briefly the key steps that we outline in the guide, and I'll show a snapshot of the tool. So for step 1, we encourage country teams to determine the frequency of the RDQA in their country office, and that would be based on the timeline of their projects and programs. Step 2 is selecting the indicators to include in the RDQA. As a rule of thumb, we encourage teams to include a variety of different types of indicators, both outputs and outcomes, and focus on the ones that are more complicated to measure. Maybe indicators that have a different data flow, and ones where we suspect that data quality problems could arise, maybe because of lack of staff or turnover, or the definition being more complicated, things like that. And this is also some of the guidance that USAID BHA provides in their guidelines. In step 3 and 4, our teams would identify the data sources for the indicators that they've selected to prioritize for the DQA. And they would identify what sources, such as registers or case files, they'll be looking at. Next slide. Step 5 is determining the sample size. So this can get quite complicated, but practically this means deciding on the number of locations that you're going to involve in the DQA process, the number of reports you're going to cross-check the numbers from, and the number of individual files that you're going to include in the assessment. And this would be, particularly for level 1 data, require quite a lot of discussion and negotiation between the M&E and the technical teams based on how much bandwidth they have to support those reviews of the individual files. And obviously the number of the volume of beneficiaries and the amount of data that you're working with can also make this reconciliation process quite challenging. Next slide. Steps 6 and 7 are all about the logistics and the preparations. So the DQA team should determine the roles and responsibilities for the assessment, including clarifying the specific process for the level 1 data review. And they should inform the local teams at the field office or health facilities about their visit. We don't encourage random spot checks in this formal RDQA process. And then step 8 is conducting the actual visits, if applicable, using the tool that we provided with the guide. Next slide. And this is a snapshot of the tool. This is the kind of cover page of the tool. So the DQA team would indicate the sector that the DQA is focusing on. It could be multiple sectors, multiple indicators, the location of the data, and some other basic information about the DQA that's being conducted, the team, the period that the review covers, etc. Next slide. And this is the rating scale that is used in the tool to assess the data against each of the criteria. So for each data quality criteria, there are a set of elements to rate when reviewing the data and conducting that review process. So the ratings will be somewhat arbitrary or somewhat subjective, I should say, but they range from 0, unsatisfactory, to 3, excellent, or it may not be applicable, certain questions or elements that are assessed for that particular indicator and set of data. Next slide. And so just to show one specific example from the tool, these are the elements that are assessed under the criteria of validity. For example, does the data collected measure what it's intended to measure? If the indicator is, for example, number of consultations, then when we're reviewing the data, that data should represent visits, consultations done, rather than unique number of patients. For all the items in the tool, the DQA team would give a rating and then sum the ratings to get the score for that criteria, and then one final score at the end. Next slide. Then we have step 9, which is entering the scores into the Excel-based tool and analyzing weaknesses and strengths of the data quality across the different criteria. Drafting a full report is optional as step 10 in the process. However, what is not optional is step 11, discussing the findings of the DQA with the program team. Then in the final step, step 12, that involves developing a tracking plan and following up that tracking plan with the recommendations for areas of improvement to be made in the collection or management of data. That recommendation template is also provided within the tool. So that concludes my part in explaining our DQA guide. We're excited to have this being rolled out across IMC, and I'm glad for this opportunity to share with the HuMEL community. Now I will turn it over to my colleague Omar, who will discuss his experience actually applying this RDQA tool. So over to you, Omar.
Thank you, Jen. Hello, everyone. I'm really excited to share our experience in Lebanon and spearheading or conducting this first of its kind RDQA. So basically, just as a background, we initiated the DQA to ensure the reliability and integrity of our data, particularly concerning the BHA KPIs, as it was required. Our aim was to identify areas of improvement, strengthen our data reporting processes, and optimize our program outcomes based on reliable data. As our first venture of the DQA, we've decided to start with the BHA KPIs that are related to health consultations. So we chose the number of consultations, number of outpatient consultations, and number of NCD consultations as output indicators. Those were selected as a pilot, just so we can see how we can move forward with the next RDQA. The selection of indicators was driven by the need for basic data that would benefit from quality improvement. And we also partnered closely with our health department, mainly with the health quality assurance division, to streamline the process. And our choice of site or facilities, mainly primary healthcare center or PHCC in short, was guided by the convenience and potential for measurable improvements. And our team leading the RDQA comprised of individuals who brought critical skills to the table, mainly the quality assurance senior specialist and the BHA health project management specialists, which both played a pivotal roles, including myself, of course, as the meal officer. So we basically collaborated with the health department on that regard and field site, and us as an M&E unit to ensure a comprehensive and insightful assessment. Next slide, please. So in terms of site selection, the selection was driven by several factors. Firstly, we considered the relevance of the significance of the PHCC in terms of the data being assessed. The PHCC handles an average volume of patients or consultations, if you will, and plays a crucial role in providing NCD consultations. Additionally, the PHCC was easily accessible for assessment team and ensured smooth logistics and timely data collection for our first venture, as I said. Furthermore, the PHCC was demonstrated willingness to actually participate in the assessment and collaborate with our team, because cooperation and engagement from the PHCC staff have great contribution to the success of the overall assessment. And overall, the selection of the specific PHCC for data DQA was based on factors such as relevance, accessibility, and cooperation to ensure a comprehensive evaluation for a specific healthcare setting. Next slide, please. Yeah, so this is the discussion about why we chose the PHCC, as I just discussed a while ago, in terms of cooperation and logistical accessibility and so on and so forth. Next slide, please. So in terms of our findings, our DQA findings were largely positive, as they demonstrated the strengths of our current practices. So in the process of conducting the regular DQA, we discovered quite a lot about the state of our data. Our findings mainly were generally positive, as you can see in the scoring sheet, reflecting the strengths of our current data management practices. Specifically, we found that we have a robust system in place for regular DQA reviews. The system is managed by dedicated staff who work tirelessly to ensure our data integrity and reliability, mainly the health quality assurance, who are incorporating quality indicators that are related to data, and our health information system officers as well. These positive outcomes are in large part as a result of a strong collaborative relationship between the health department and the field site team, along with the MEAL team. Upon identifying areas for improvement, we communicated these insights to the relevant parties, mainly the MEAL manager and the central health team, and the project manager as well. And currently, these areas are being tracked for improvements, and we are planning to develop actually a standard operating procedure for data cleaning to enhance our data quality further, or basically to standardize the way data is being cleaned across governorates in Lebanon. So in terms of challenges, I'm going to discuss them orally, if you will. Basically, our results rendered a 95% overall DQA, which is within the no risk category. However, we did have some challenges through the process, just to kind of gauge our way in terms of how we need to proceed with the next upcoming DQA, because we will be selecting more complex indicators. So we needed to standardize, as I said before, standardize our data cleaning processes across governorates, and that needs an SOP so that all field sites perform it in a standard manner. Real-time availability of data. So usually we have an electronic health record system, which is called Phoenix, which is a national electronic health record system in Lebanon. But given the large data sets, it is not possible to actually provide real data availability to kind of tackle on-the-spot data errors. So we plan to expand through future projects and fundings to be able to have that possibility, so we can be able to have real-time availability through upgrading our servers. And actually, I got this news yesterday to actually connect it to Power BI, so we can have real-time data insights. And also another challenge was resistance from the PHCC staff to retrospectively correct data on the system for accurate unique counting as well. So you would have PHCC staff being resistant to retrospectively correct data because there's nothing in it for them. So we have something called performance-based financing, and through that performance-based financing, we would have an indicator on data by the quality health assurance division, whereby they would assess if the data quality is up to par, if you will. And based on that indicator, they would be awarded a certain amount of sum of money just to kind of positively reinforce them to correct data. Next slide, please. So in terms of lessons learned, let's talk about the lessons we've learned. Basically, our biggest takeaway from this DQA was recognizing the power of teamwork. You cannot have work in silos. The meal department alone, it needs to have to be in a collaborative manner with the health department, which was a good thing given that they had a quality team on board. Cross-departmental collaboration was quite crucial. We also saw firsthand that how these elements can drive significant improvement in data quality. Moreover, this experience underscored our commitment to continuous learning and quality improvement. We've learned the immense value of having a dedicated staff to review and assure data quality regularly. Also, we saw the efficiency of our monitoring tools, medical records assessment, which is conducted on the field by the quality assurance team, and the data cleaning tool as well, which we will be revamping or improving. Starting with basic indicators was a fruitful approach, and we plan to apply the lessons learned from this process to improve more complex KPIs in the future. So basically, in conclusion, our journey with the DQA tool has been quite insightful, and we had our fair share of challenges, but these were opportunities for us to learn and improve. And our data integrity has never been better, and we look forward to continuously enhance it. Thank you very much. And if you have any questions, you can reach out in person. Through this call, or probably email me. My email is Makki@internationalmedicalcorps.org. Thank you. Over to you, Allison.
Thank you so much, Omar and Jennifer. Are there any questions from the group? I'll give you all a minute to digest. Omar, I was really excited to hear you say that you're using Power BI. That was one question I had, Jennifer, when you were saying that an optional deliverable is a DQA report. I wondered if you all had discussed inclusion of something like Power BI or some other dashboarding tool in the toolkit as an alternative, just something that might be quicker or easier to reference more regularly than a DQA report.
We had not, unless I missed some of the discussions while the tool was being developed. But that's a really good suggestion. I might bring that back to my team. Yeah, we did discuss a bit in the original guide. It was noted as just a step, not as optional, but something that was recommended to develop a report. And after some discussion, we know having kind of narrative reports often turns people off. It makes the process overly complicated for something that should be more straightforward. And so we had decided to make that narrative report as optional. But I do like that idea of a dashboard.
Just to build upon what Jennifer was also saying, basically, not in all country missions are there electronic health record systems available, even in other sectors. For example, in Lebanon, we have the GBV sector, and they do not have a database management system, if you will, so they're still on Excel. So I guess that's why it's still a recommendation, I presume. However, I think one of our upcoming members are gonna present, and I've noticed that they had the Power BI. So it kind of inspired me and reminded me that we're actually going to kickstart it as a personal effort, if you will, just so we can have real-time data and be able to clean in prior to the reporting, just so we're not kind of choked during the last minute during reporting, during global country reporting or whatnot. So I just got the inspiration from there.
Yeah, that's really great. And I see the questions pouring in the chat. We have one. Can you please kindly share more about the sampling method for a DQA?
Sure. I mean, from my end, what I can do is basically, I think Jennifer was alluding that it was quite tricky. Definitely, you can correct me there, Jennifer. In terms of our sampling method, we basically sampled one of the primary healthcare centers. So we have 5 zonal areas or field sites, if you will. We have Beirut and Mount Lebanon. We have Bekaa. We have Akkar. We have the south. And basically, we chose Bekaa area, and because it had one of its PHCs under BHA. And given the logistics, so it was more of a convenience sampling and availability of that PHCC, and also willingness of that PHCC or PHCC director to actually engage in DQA and use it as a success story for other facilities or PHCCs to kind of also agree in our upcoming DQA sessions as well, DQA ventures, if you will. And I guess that's about it in terms of sampling. Basically, sampling was not that difficult in terms of how we need to select data for that indicator, given that all the data was kind of available in the electronic health record system. So it wasn't a sample per se for a particular month. It was the whole data from the beginning of the project, given that it's all readily available and kind of could be manipulated and cleaned on the spot easily, which is not, as I said before, feasible with other sectors or other country missions who might not have an electronic health record system. Maybe Jennifer would want to build more upon that.
Yeah, just to say, I mean, in our guidance, in terms of sampling the site locations for the review, there is a recommendation to look at 20%, to randomly select 20% of all sites where that type of data is held. But if the country office has only a small number of sites, it could be higher. It could be 50% of sites, all the way up to all sites being selected. And then for the sampling of individual case files, that is very much a based on discussion with the program teams. Obviously, we're not going to be reviewing 100% of beneficiaries' case files. So it's determining based on kind of the volume of materials available at the site and the ability of the technical and program staff to participate at that point in time in the work. The decision would be made on the number of sites and the number of files to review. But the idea is to really get as representative a sense of the data as possible, with a little bit of kind of purposive selection of areas where you think there might be problems and that might not come out in purely random selection.
Thanks so much, Jennifer and Omar, and we are flying through our Q&A period. I'm going to have to turn it over to Willie. I don't want to eat into his time, but there are lots of questions in the chat. If you all wouldn't mind responding to those there, and if we have time after Willie's presentation, we might be able to revisit a few of these. And they may require some additional follow-up from us since there are so many. Great to see you all engaged. Okay, well, thank you both again. That was great. Our next speaker is Wilson or Willie Gu. Willie is a meal technical advisor at CRS and will be presenting on DQA for the feedback, complaints, and response mechanism in Moldova. Willie, over to you.
Great, thank you. Hello, everybody. Good morning, good evening, afternoon. Like Allison said, I'm a meal technical advisor, and I'm specifically working with our partner organizations who are assisting Ukrainian refugees and host communities in the countries around Ukraine, which is why I got to work with our team in Moldova. I decided to present this topic because the project is a cash project, and cash is huge in humanitarian response. Feedback, complaints, and response mechanisms are also huge in humanitarian response, as well as data-driven decision making. So I thought there were a lot of very important topics here. And so let's dive right in. Next, please. So I'll give you a little bit of details about our project. It started right when the war began in Ukraine. It's a cash distribution project led by UNHCR. You might have a very similar project running yourself. Next, please. So at the highest point, we were serving about 115,000 individuals across the entire country. So this was a countrywide cash project. Next. We, CRS, Catholic Relief Services, Caritas Moldova, and Diaconia were all jointly implementing. Caritas Moldova and Diaconia are our Moldovan partner organizations. And so together we provide staff at these enrollment centers, and we provide services that are related to cash distribution. So we register folks, we verify, we distribute cards, and we troubleshoot. And next, yes. And then the focus of today is on our helpline. So our helpline, we have 12 operators. And again, it's a helpline that serves the entire cash project across the entire country. Next. So our data quality assessment, we focused on one indicator, which you see here, percentage of feedback responded to in a timely manner. Next. And so just like Jennifer and Omar mentioned, we have different data quality standards. And although we decided to adapt the questions for each standard to make it more relevant for a feedback, complaints, and response mechanism data quality assessment. So for validity, we decided to focus on appropriate categorization of data. Is feedback sufficiently captured, and do beneficiaries have adequate access to feedback? So, we really wanted to know if people had access, if people knew how to provide the feedback. All right. The next one is on reliability. So, this one is relatively, it's the same as the previous one. Next, please. So for timeliness, we wanted to really focus on, did we respond to feedback in a timely fashion, as well as checking if data were analyzed and used for decision-making. With our cash distributions, we recognize that if a card doesn't work or if people don't have access to cash, we really need to resolve that problem quickly because they need to buy items to meet their basic needs. So we adapted that for our DQA. Next, please. We will also address the sufficient level of detail, and this really focused on disaggregation. So as we're receiving the feedback data, knowing the genders of the folks who are providing feedback, where they're from, other categories for disaggregation. Next. And of course, we also had to focus on integrity, but for our feedback, we need to really make sure that sensitive feedback is not is being appropriately stored and transmitted to the right people. All right. Next. Right. So now I'm going to share just some basic. I'm going to share some recommendations or thoughts for you if you are thinking about doing a data quality assessment for your feedback, complaints, and response mechanism. So the first thing to think about is that a standard operating procedure for your FCRM made it really easy to assess data quality. So for example, our SOPs in Moldova, we had clear instructions for the helpline operators. We had very clear examples of how to categorize feedback. We even had standardized FAQs, frequently asked questions. So oftentimes you would get the same questions over and over and over again from different people, but we wanted to make sure we had a standard response to those same questions. And I know that SOPs can be very long. They can take a lot of time to develop, but I would really encourage the investment in them, because not only does it make DQAs easier for people like me, but it's also much easier for your helpline operators, for anybody running the feedback or receiving feedback to deliver a high quality system. Now, of course, an SOP won't solve everything, but they are an important step in making sure you have data quality and for assessing it. Next, please. Right, so in-person monitoring. So that was still helpful, right? I didn't just rely on a desk review of the SOP. I was able to talk to some of the project officers and project managers and really understand how feedback was received. So I'll give you a picture. The helpline office is actually in a different office from the project implementation team. They're all in one room, 12 of them, with their computers, with their tablets, with their headsets, and they have the gray foam sound paneling on the wall so the other people in the office can't hear all the conversations. And the project team meets with the helpline operators weekly. They make a weekly visit. They answer any questions. They review the previous week's feedback data. Maybe there's some incorrect categorizations. They also share updates and information because things change quickly. And so the helpline, they need to have the right information to pass on to the people who are calling. These weekly visits are also an opportunity to sit and watch operators take calls. And so by being able to actually see the operators, this led to the observation that helpline operators weren't actually reading the standardized messages, standardized responses from the SOP, right? The SOP that I just talked about, remember I said they had these standardized responses, but when we actually we saw that they weren't being used. And so that led to us having the solution of providing, because the SOP is this very long document, we decided to print out physical copies of the standardized responses. That way the helpline operators could have that right next to them. And that way they could more easily respond to these frequently asked questions. So just the recommendation here is the recommendation here is to consider also in-person monitoring of the actual data collection. I think you can learn a lot of things that might not be available if you're just looking at the data, that was collected. All right, next, please. Right, so ComCare and Power BI dashboard make it easier to assess data quality. So all of our feedback is recorded in a ComCare application, and then that data gets piped over to a Power BI dashboard, which is updated regularly, and that our helpline operators also have access to this Power BI dashboard, not only to see all of the feedback, but also to see some basic analysis and to also see how we're doing on our indicator, what percentage of feedback were responded to in a timely manner. Now, for me, when I was doing the data quality assessment, this helped me a lot, because here was a documented and standardized way to do the analysis, to receive feedback, to categorize feedback. I could just easily check that everything was regularly updated and that the updates were automatic. I could also open the Power BI source document, the Power BI desktop file, to see how the indicator was calculated. And I could see that this was applied, that this was standard. It wasn't an ad hoc calculation. So again, same with SOP. I know that ComCare and Power BI, they take time to learn, they take time to set up, but it's not just to do it, it's also to improve your data quality. And if you know you have to do a data quality assessment, I think sometimes VHA comes from the very beginning and they say, we want to do a data quality assessment at some point in the project. If you know that's coming, or if you know you have internal data quality assessments coming, maybe that could be some motivation to set up a data management system. Of course, it doesn't have to be in ComCare and Power BI. It could be in Excel. It could be a paper Excel combination. But just investing in a good data management system should lead to data quality, better data quality, or it can help the data quality assessor identify where your data management system might have some areas of improvement. All right, next, please. And so the last point that I want to share with you is thinking about triangulation for even around feedback, complaints, and response mechanisms. So it just happened that UNHCR, the donor, conducted a PDM, and in this PDM, they asked questions about the helpline. And this PDM was actually shared to all cash recipients. So that was very useful to see out of everybody who knew about the helpline. And it wasn't everybody. Not everybody knew about the helpline, which is important data for that, to knowing whether or not we're receiving all the feedback that we should be receiving. So not only did UNHCR do a PDM, we internally also did our own internal helpline satisfaction survey. And this was a mobile survey. We selected the people who had already called the helpline and we asked about their satisfaction. It was relatively low effort because we just pulled phone numbers and we sent text messages with a link to a Microsoft Forms survey, something like that. And so both of these surveys, the UNHCR PDM and our internal satisfaction survey, helped us triangulate and look at our raw feedback data to see how many, how quickly were we responding to feedback. So for example, in our internal satisfaction survey, we found a percentage of people were not satisfied with how long it took to respond to feedback, or maybe they were calling, but there were not enough helpline operators, so it took time for them to register the feedback. And this was in line with our analysis of the actual time it took to resolve the feedback, right? All right, next, please. Right, so of course, I'm just going to sum up. So we have SOPs, right? Invest in your FCRM SOPs. I have a triangle for triangulation. Thinking about doing in-person monitoring and investing in Power BI. I put Power BI here just because I think that's what will stick with you. But the bigger point is data management. Invest in a good data management system for your feedback, complaints, and response mechanisms. All right, that's all I have for today. Here's my email if you have questions, and I'm also happy to answer any questions, whatever we have time for now. Thank you.
Thanks so much, Willie. Are there any questions for Willie? I suspect there will be. And also do feel free to come off mute if you'd like, instead of putting them in the chat.
I have one question related to, I saw there is a 12 operator. You are saying you are using the hotline. You have also 12 operators. That means you have 12 focal person in managing hotline?
No, so we have 12 people who receive phone calls, and then we have one helpline manager. So that's how our team is structured for the helpline.
Okay, thank you.
Mm-hmm.
Mariam, go ahead.
Yes, hi everyone. I have a question. Do you have a database to collect or to register the community feedback in order then you can use it in the Power BI? I'm sorry if you mentioned that and I didn't pay attention. Thank you.
Yeah, no problem. So the way it was structured was the helpline was the focus of our data quality assessment. I think when we receive feedback through other channels, like whether that's in person or in a community, I think they are working towards, I think right now they do have it all in one database. It's all one application to receive all feedback. Although for this data quality assessment, it was really just focusing on the helpline.
All right, we do have another question about developing DQA databases for RIFSAs. I'm not sure that's relevant to the speakers we have here. Willie, have you supported a RIFSA DQA by chance?
I have not, only with BHA.
Okay, that may require some additional follow-up on our end, but great question. Any others? Okay, I'm looking through to see. Oh, Veronica, go ahead.
Thanks so much, Willie, for the interesting presentation. I'm wondering if you might be able to speak to the involvement of other people besides the helpline operators and help hotline manager in the DQA, like other programming staff who might also be involved in like providing a response to someone and
to responding to feedback?
Yeah, I'm just wondering, like in cases where the helpline operator might not have like the answer to someone's question and therefore the timeliness of the response like depends on others on the team. Yeah, if they were involved in this DQA as well.
Yeah, so for the DQA, I spoke to all the project manager as well as the meal officer. And as well as, like I mentioned, talking to the helpline operators. And how it works is that the Power BI dashboard is just all of the feedback. So both the helpline operators as well as the project manager and project officers, they can all see the feedback. So the project manager, I actually know she checks it every day. And just uses the Power BI dashboard to filter the feedback to see, filter by how many days have passed since it was first recorded. And then she will follow up with the right people to either give the right answer or to maybe they need to follow up with UNHCR about something. But it's really up to the program manager right now to check it regularly, the dashboard, and then kind of route how to more quickly respond to the feedback. I'll also say that when the feedback are recorded, I think now this was interesting. It wasn't part of the data quality assessment, but I do think that there are many details recorded for when the feedback is recorded. So there's not too much back and forth to figure out what the actual feedback was. The operators get as much information as they can before they, and if they can't resolve it, then it goes into the database, and then the program manager then looks in the database to figure out how best to resolve the feedback.
Willie, we have another question from the chat.
Okay.
Regarding the feedback collection, we use consultation meeting. Oh, sorry, I'm not sure that was the question. Oh, just a comment from Raj.
Great.
Although Raj, maybe you'd like to come off mute and add. Raj says, regarding the feedback collection, we use consultation meetings with children, youth, and adults separately.
I think that's great, right? Because like with a helpline, you're limited. You can only call in if you have a phone or credit, and so of course the helpline is not shouldn't be the only feedback channel that we have. So it's great to see that you're talking to children, youth, and adults separately, and you're making sure you're talking to children and youth as well and getting feedback. That's great. And I would also say, like, I think this was interesting because our role was so specific to, do the, operations work of cash distributions as well as run the helpline. We actually had a FCRM indicator in our agreement with UNHCR. And I don't think you see that always, right? So This could be either an opportunity, maybe you want to hold yourself to a high standard and include an indicator in your log frame around responding to having a timely response to feedback. And then that keeps you accountable. Or maybe if you're a donor or if you have subrecipients, making that a requirement. So that way they have to try to respond to feedback in a timely manner.
All right, and a request from Clara to share that indicator, if you don't mind, Willie.
Yeah, I can. I'll share that. I guess, is that like the indicator itself, or also all of the associated definitions and stuff like that?
Good question, Clara. Indicator to
yeah.
start.
Great. Let me see if I can find it.
Yeah, no rush, Willie. We can also follow up with that.
Yeah.
Any other questions? We have a couple more minutes. Thanks again, Jennifer and Omar, for answering all of those in the chat. I think maybe since this discussion was so rich, I'll probably compile these in an FAQ to share after today's webinar. All right, well, if there are no additional questions, thanks everyone for joining us today to discuss. And again, a special thank you to our presenters. A recording of today's session and the slides will be uploaded to the HuMEL site on the FSN network, and you'll find their contact details there in the slides. Thanks, and have a great rest of your day. We look forward to seeing you next time. Bye, everyone.
Bye-bye.